We're focusing on women's health today on What's Up Doc. Did you know that polycystic ovarian syndrome, or PCOS, is one of the most common issues faced by women of reproductive age in Trinidad and Tobago? In fact, there may be implications to your health, as this condition can be related to non-communicable diseases such as hypertension and diabetes. By age 40% of women with PCOS will develop prediabetes or diabetes. Today I welcome Dr. Shireen Kulu, an obstetrician and gynecologist in Trinidad and Tobago.
Today's Vitaminate is vitamin E. Vitamin E is a vitamin that dissolves in fat. It is an important vitamin required for the proper function of many organs in the body. It is also an antioxidant. Vitamin E is found in plant-based oils, nuts, seeds, fruits, and vegetables, peanuts, peanut butter, beet greens, collard greens, spinach, pumpkin, red bell peppers, mango, and avocado. And that was today's Vitaminute.
So, Dr. Kulu, what exactly is PCOS, polycystic ovarian disease?
Okay. So polycystic ovary syndrome is a very common disorder that we see a lot more now than we used to before. And we call it a metabolic disease. And it's because there are high hormonal levels of androgen, which is a male hormone. Now, we all have male hormones, men and women, but with women, our levels are lower. And because we know that the levels are supposed to be lower, there is obviously something causing the level to be higher, right. And that is what is responsible for the polycystic ovary syndrome. So we may have ultrasound findings or we may not.
So what exactly is the syndrome, polycystic?
So that's interesting. If you're asking the cause, we still don't know exactly what the cause is. But we do have theories. There's a pathophysiology that we can look at. And it's important to explain to a patient exactly what is causing the problem for them to understand why they need to manage the problem,
right,
with everything, not just with polycystic ovaries.
Is there a genetic link? Is it runs in the families?
Definitely, we've been seeing that there is a family history of polycystic ovaries. So first of all, if there is someone in the family who has polycystic ovaries, you should get yourself checked as early as possible so that you can prevent. So I am seeing teenagers now with polycystic ovaries. So I would say as early as when you start what we call menarche, which is when you start seeing your first period. Within the first 2 to 3 years, you should get a checkup at your gynecologist, right, and make that a visit for a well woman, as we call it, well woman visit. So you start your checkups, you get used to, seeing a gynecologist, what's important, and talk about other aspects as well. But with regard to polycystic ovaries, family history, get a checkup early.
Well, we're not sure, as you said, what causes polycystic ovaries, but your risk factors are certainly genetics. What about obesity? Being overweight, is that a risk factor for it?
Correct. So we see more patients with polycystic if they're obese, but there are the small-built patients who also have polycystic ovaries. So the way I would explain polycystic ovaries to my patients is being metabolic, yes, but it's a high insulin or insulin resistance factors that can cause the high androgen factors or the high testosterone levels in the blood. So if we look at the pathophysiology and we say, okay, a patient comes in and I will say, you either have a family history of polycystic, or you have a family history of diabetes, and the aspect of insulin resistance is what we look at as the underlying cause. That's the main one. So because insulin levels will more than likely go up and cause androgen levels to go up.
Right.
The androgen levels is what's responsible for the symptoms that we see in patients with that particular type.
Which are?
So we see obesity. Since you asked about obesity, so that being one of the factors. We see hair loss. We see acne from the androgens, and we see facial hair, or what we call a male distribution of hair growth, which is hirsutism, not just facial, but the male distribution as well.
So on the chest and the back.
Around the nipple, acne on the back. We see the male distribution in the pubic area coming up to the umbilicus. You can see hair distribution there. So that may be one of the clues that you're looking for. And then, of course, oily skin. Those are the androgenic factors.
You mentioned hair loss. Hair loss is a specific pattern like male pattern baldness. That's kind of hair loss, or it's a generalized hair loss?
Well, it's not necessarily male pattern, but hair loss on the head, because we talk about hirsutism being hair growth, which is like the male pattern,
right.
But hair loss from your hair. So lots of patients will come and say that, yeah, I've been losing a lot of hair. My hair is dropping. What's causing it? And you start looking for other underlying problems, and you really have to look at thyroid as well. We forget about the thyroid, the prolactin levels, the diabetics, and you have to screen for those things, even though you may think they have polycystic.
Okay. Now, with polycystic ovaries, a lot of the women that come to me too, they say that their periods are irregular. Is that one of the common symptoms?
Yes. Irregular menstrual periods is from the estrogen levels that go crazy as well. And more commonly, infertility. So that is one of the top things that I would see in the office.
They come to you because they've been trying and they cannot
trying to get pregnant, not getting pregnant, may have regular periods, and may look absolutely normal in terms of the BMI and not obese. But when you do further investigations and you do your ultrasound scan and you see a whole lot of multiple little cysts. So some people mix up polycystic ovaries and ovarian cysts.
Yes.
And that's important to point out, because you hear cysts and you think surgery.
Correct.
No, not the case. So polycystic ovaries, just to make it clear, and you in your specialty would know that you're looking for multiple small cysts less than 9 millimeters. And it would be on the periphery of the ovary.
The string of pearls.
String of black pearls, as we call it.
Yeah,
correct.
Yeah. So that's my little beef, though, is sometimes you get the diagnosis being overcalled on ultrasound. You're looking for specific features on ultrasound. So my question to you is, you have a young teen who's just started her periods at, say, 12, 13. Generally, girls' periods tend to be a little erratic and irregular anyway. How do I know as a mom that this is something I need to pay attention to and get her to see a gynecologist? What other telltale signs must I look for? Or once she has irregular periods, empirically take her to the doctor?
I believe it would depend on the family history as well.
Okay.
So if a young child starts seeing her period, it starts being irregular, yes, within the first year, it is expected to be irregular, and then it settles down to regular monthly cycles. But if she has a strong family history of polycystic ovaries, I would definitely advise her to have an ultrasound scan done. And no, you do not need to put a probe in the vagina to have a pelvic ultrasound done on a virgin.
Right.
You can have a full bladder and have it done on the abdomen.
And that will give enough information.
Correct, we get enough information from that. So some people are scared to go to the gynecologist because the first thing you think of is you're going to have an examination done. But no, we do not do that with virgins.
Okay.
So we would carry on to do the examination. But we'll also, okay, so if you don't have a family history and you're now looking to see, should I take my daughter, should I observe? If within the first year she's not settling, you go to your gynecologist. However, if she has acne breakouts, if she's putting on weight rapidly, if you see distribution of hair growth looking a little odd, then you'll want to go.
It feels like that's all teens because they're in exam mode.
True.
They're stressed out, so their cortisol levels are high. They have acne anyway. They eat badly. They may not exercise, again, more academic oriented, so they may not devote their time to outdoors as they should. So
I'm glad that you said that, because those are some of the factors that actually precipitate the onset and the symptoms that you would be looking for. Stress being one, lack of exercise, bad eating habits, unhealthy lifestyle. And that's the first way that we would manage patients with polycystic ovaries. It's not all medical.
Right, so that's your first line for treating these girls.
Definitely.
Junk food, you tell them stay off of it?
I do, and it's important. And you see, when you see the results of someone coming in your office now, and then they come 6 months from now, and they follow instructions, and they see for themselves that they look better, they feel better, and everything settles, then they are stimulated enough to be responsible enough. Yes.
Yeah.
I think it's just mindset as well.
So in a teen, I mean, that's such a ticklish situation, though, in terms of telling a teen, you need to lose some weight.
Yes, so that's another thing that I think people neglect in patients with polycystic ovaries, the mental health. And they are depressed individuals as well. You can't just tackle the medical aspect of it, you have to tackle the mental aspect of it. So the depression, and so that goes with polycystic ovaries.
Yeah.
You have to get some other contribution, psychology, a psychologist, you know, you don't want to go to a psychiatrist, but maybe the therapy. A lot of the time that I spend with my patients in my office, I dedicate to also talking. It's not just about medicine. When you do holistic management of a patient and you take your time to explain things and realize what they're thinking and feeling, and you can reach out to them differently, that's half of your treatment there. Huh?
Yeah, they become more compliant because they understand now the rationale behind the treatment.
Correct, and that's important.
Treatment for polycystic ovaries, besides the conservative diet, exercise, weight loss, what other treatment options are there available for these girls,
so you
women?
So the way that you say it, diet, exercise, weight loss, any patient hearing that is going to say, well, I don't need to go to the doctor to hear them say that, right?
Yeah.
But when you explain to them a little bit more, maybe a nutritionist might be helpful, or they can try on their own. But you know, when people are more disciplined in terms of spending money to go to the gym to do exercise, they will exercise as opposed to saying, I'm going to do it at home.
Right.
So these small factors play a huge role. I have patients who just do the diet and exercise alone with no medication, and they completely free of the polycystic in 6 months.
I would like for you to tell the audience, though, if you are diagnosed with polycystic ovaries, is this a life diagnosis or you can't get it treated?
So there is treatment available that would be the diet and exercise to start with, but you are stuck with polycystic for life in terms of the diagnosis. But the problem, medical treatment can 80% give you a success rate.
And what does the medical treatment look like?
So medical treatment will be, some people go on a contraceptive pill. I want to re-emphasize now that that is not treatment alone for polycystic ovaries. It will treat the symptoms, which will be bringing the androgen levels down with some of the contraceptive pills,
right,
and regulating your period, and also helping sometimes with the acne and the facial hair. But that is not the main form of treatment. Now, before, a few years ago, we used to be looking at treatment with a tablet called glucophage, which is metformin.
Yeah.
And it's a tablet that targets the insulin resistance levels. So then the pathophysiology, once you understand, you know, that's what we need to bring down. And exercise and diet does the same thing, by the way. It brings that down.
Correct.
So once you target that, which you know is a problem, the metformin does that. It also helps because it helps the obese people lose weight, but it doesn't help with the small people who have a small BMI, because they lose more weight, so we don't want to give them that. So now, within the last couple of years, there's more natural treatment options. So we know that there are vitamin B deficiencies. There's a tablet that the US is using a lot now. It's called inositol. Inositol is also natural. be in carbohydrate. And because it is natural, people are more willing to take it as opposed to medication. And believe me, it does an amazing job.
Great results.
I have been seeing great results within 2 months.
You use it generally for your smaller patients or all of them?
So, interesting question. People go to the pharmacy because, everybody's on social media now. So they read, inositol works. So they go, they buy it, they take it. And they come to the doctor and, doc, I'm taking so. That's fine. I have been able to triage my patients. I still stick with the metformin for the more obese patients.
Right.
The smaller ones, I've been using the inositol. But recent studies have shown that you can actually use both together.
Okay.
With no ill effects.
Okay,
Yes.
great. So before we wrap up, if there was one piece of advice that you would like to leave with those viewers out there, one gold nugget about polycystic ovaries, what would that be?
I will say to be proactive. Don't wait for a diagnosis. Don't wait for the symptoms. Change your lifestyle habits. Eat healthy. Do your exercises and prevent that problem from coming on.
Thank you very much.
You're very welcome.
discuss gestational diabetes, a form of diabetes which develops in pregnant women. This medical condition can affect both the fetus and mother, but can be managed to ensure that you have a healthy pregnancy and a healthy baby.
From the first trimester, there's an increased risk of miscarriages, an increased risk of fetal abnormalities. So these are congenital. The baby could be born with an abnormality.